Imagine two patients are rushed through the emergency room doors.
Okay, setting the scene.
Yeah. So patient A has this tiny localized bleed near the center of their brain, and they are rapidly deteriorating, like literally fighting for their life.
For a critical presentation.
But then patient B has blood pooling near the surface of their brain, presenting with symptoms that perfectly mimic a uniformly fatal aneurysm.
And yet, patient B will likely walk out of the hospital a few weeks later with, minimal physical deficits.
Exactly. It's wild. And today on the deep dive, we are decoding a massive stack of medical notes on supratentorial intracerebral hemorrhage.
Which is a very long way of saying bleeding in the upper regions of the brain.
Right. And we're looking at why the exact anatomical zip code of a brain bleed dictates, well, absolutely everything about a patient's survival.
Yeah, we're looking at bleeding inside the brain tissue itself, specifically above the tentorium. And the overarching theme across all the sources we're analyzing today is that treating a supratentorial hemorrhage as just this one monolithic disease is a fundamental clinical error.
Because the brain isn't just one uniform organ.
Exactly. The brain is a highly specialized, functionally compartmentalized map. Geography is quite literally destiny here.
And the sources outline 4 distinct geographic zones for these brain bleeds, right? You've got the putamenal, the thalamic, the caudate, and the lobar regions.
Those are the big 4.
Okay, let's unpack this by starting with the heavy hitter, the putamen, which accounts for about 35% of the cases we're looking at.
Yeah, the putamen is the single most common site for these hemorrhages.
Yeah.
And what really stands out in the literature is the sheer breadth of the clinical severity.
Like how different it can look from patient to patient.
Right. I mean, a patient can present with a tiny, isolated bleed resulting in just pure motor hemiparesis or perhaps a mild dysarthria. It's super subtle.
Just a little weakness or slurred speech.
Exactly. But if that hematoma expands, the physical mass of the blood starts compressing the adjacent internal capsule, which is where all those dense motor fibers are traveling.
Which explains the classic textbook diagnostic triad, the sources detail.
Yeah, it's a very clear picture.
Because a massive putamenal hematoma in the dominant hemisphere presents with that dense, uniform weakness across the face, the arm, and the leg on one side, paired with genuine sensory loss and severe aphasia. The anatomical expansion of the clot just simply bulldozes through those descending pathways.
The mechanical pressure is just devastating. And if that expanding hematoma ultimately ruptures the surrounding tissue and breaches the ventricles, you see patients presenting in a deep coma with decerebrate rigidity.
Oh, wow. So they're completely unresponsive with that stiff, arched posturing.
Right. That posturing indicates the pressure has referred all the way down, literally compressing the brainstem.
Right.
But, looking at the historical data on these putamenal bleeds reveals one of the most fascinating diagnostic shifts in modern neurology.
Oh, the mortality statistics. I was reading through the section, and it genuinely changes how you think about medical data.
It really does.
Because today, in the modern CT era, the mortality rate for a putamenal hemorrhage sits at around 37%. But if you look at the literature from before CT scans existed, the recorded mortality rate was hovering between like 65 and 75%.
Yeah, which is a massive gap. On paper, a drop from 75% to 37% looks like a miraculous therapeutic breakthrough.
Right. You would assume they invented a revolutionary surgical technique or, I don't know, a targeted pharmaceutical intervention.
But there was no new treatment at all.
None. It was purely an upgrade in visibility. I keep thinking about this like the evolution of astronomy.
Oh, that's a good way to look at it.
Yeah, like when we built more powerful telescopes, we didn't suddenly create billions of new stars in the universe. We just finally gained the capacity to see the smaller, dimmer stars that were already sitting there in the dark.
Exactly.
The invention of the CT scanner just acted as our better telescope.
That analogy captures the mechanism of this statistical shift perfectly. Because prior to the advent of the CT scan, neurologists were basically flying blind.
Just guessing based on symptoms.
Right. They were only successfully diagnosing intracerebral hemorrhages in patients who presented with massive catastrophic bleeds. The ones that invariably resulted in death or profound disability, often confirmed only at autopsy.
Wow. So the denominator in their mortality calculation only included the absolute most severe end of the spectrum.
Exactly. Because the dimmer stars, like your analogy, the patients with those small putamenal bleeds causing just a bit of dysarthria or mild hemiparesis, They were completely misdiagnosed.
The doctors just assumed they were looking at ischemic infarcts, right? Like
Yeah.
regular blood clot strokes.
Yes, the technology rewrote the mortality statistics simply by allowing us to accurately categorize the disease across its entire spectrum. It broadened the denominator.
That is so wild to think about.
But even with advanced imaging, the modern data points to one strictly dire prognostic marker for putamental bleeds, and that's ventricular extension.
When the blood breaks into the fluid system.
Right. Once the blood from the putamen violently breaches the brain's internal fluid system, the prognosis drops precipitously. It signals that the sheer volume of the bleed has just completely overwhelmed the local tissue architecture.
Which makes sense mechanically. But if the putamen acts like a slow pressure cooker that eventually bursts, I want to shift geographically to a structure that is positioned much closer to the brain's central plumbing.
Ah, the thalamus.
Yeah, the thalamic hemorrhage, which makes up about 10 to 15% of these cases. The presentation here is noted in the sources to be drastically more abrupt than the putamen.
We're moving medially here. The thalamus sits right alongside the third ventricle.
Right in the center.
Yeah. And because of that medial location, a hematoma forming in the thalamus doesn't need to expand very far before it communicates with the ventricular system. The blood just spills into the fluid-filled spaces incredibly early in the clinical course.
Which initiates a massive cascade of fluid dynamics.
Wow.
We're talking about the choroid plexus constantly producing cerebrospinal fluid, and suddenly a clot from the thalamus drops into the system and obstructs the aqueduct of Sylvius.
It creates a blockage.
Right, so you have a closed system filling with fluid, creating rapid obstructive hydrocephalus.
And the patient's level of consciousness deteriorates rapidly as that intracranial pressure spikes. The prognosis for a thalamic bleed relies directly on the initial size of the hematoma and the depth of that altered consciousness upon arrival at the hospital.
Okay, I need to push back on the clinical logic here for a second.
Sure.
Because we just established that if blood extends into the ventricles from a putamental bleed, it is a strictly dire prognostic marker, right? Like essentially an indicator of irreversible catastrophic tissue destruction.
Yes, generally speaking.
So now we have blood abruptly hitting the ventricles from the thalamus, blocking the aqueduct and causing rapid hydrocephalus. Why isn't this thalamic ventricular extension just an immediate death sentence? Like, what makes this physiologically different?
That's a great question, and you are isolating the most critical life-saving distinction in the sources.
Okay.
The ventricular extension of the putamen represents the endpoint of massive tissue destruction. The blood has chewed through a vast amount of parenchyma to get to the fluid.
It had to destroy a lot of brain to get there.
Exactly. But in the thalamus, because it sits directly adjacent to the ventricle, the blood enters the fluid system very early, often before massive structural tissue destruction has occurred. The subsequent hydrocephalus is primarily a mechanical plumbing issue.
Oh, I see. So it's an obstructive pressure issue rather than purely a tissue necrosis issue.
Furthermore, that specific mechanical issue offers a genuine, actionable target for neurosurgeons.
Wait, they can actually fix it?
They can intervene by placing a ventriculostomy. By inserting an external ventricular drain, or EVD, they can physically bypass the aqueductal obstruction, siphon off the accumulating cerebrospinal fluid, and relieve the intracranial pressure.
Wow.
And they can do that before it causes fatal secondary compressive damage to the brainstem.
So the thalamic hydrocephalus, while terrifying in its rapid onset, transitions from being a grim marker of inevitable death into a mechanical problem that can actively be reversed. You're fundamentally changing the pressure dynamics of the skull.
It dictates a highly aggressive neurosurgical approach.
Yeah.
Because you have a tangible mechanism to reverse the decline. You have something you can actually do.
That is incredible. Okay, so here's where it gets really interesting. We move from the thalamus to the third zone, which is the rarest bleed on our list, accounting for only about 5% of cases, the caudate hemorrhage.
Yeah, only about 5%. The head of the caudate nucleus is fed by the penetrating arteries coming off the anterior and middle cerebral arteries, and hypertension is the usual culprit for rupture here.
Just high blood pressure over time.
Right. But clinically, this hemorrhage is a chameleon. It doesn't present like a traditional intracerebral parenchymal bleed at all.
The sources call it the great mimic. It perfectly replicates an entirely different, incredibly dangerous neurovascular emergency.
The ruptured anterior communicating artery aneurysm.
Right, which is a classic subarachnoid hemorrhage. I'm trying to picture the clinical presentation in the ER. The patient must be coming in with signs of massive meningeal irritation and raised intracranial pressure.
Oh, absolutely. A thunderclap headache, severe neutral rigidity.
Like a really stiff neck.
Yes. Vomiting and profound confusion. The patient is often exhibiting complex neuropsychological signs as well. Disorientation, memory disturbances, and abulia, where they simply lack the will to initiate action or speech.
They just kind of sit there and do nothing.
Exactly.
But the telltale sign is what is absent from the physical exam. Because in the putamen and the thalamus, we saw massive focal deficits, right? The dense hemiparesis, the facial droop.
Right.
If the caudate bleed is mimicking an aneurysm, they shouldn't have those focal motor signs.
And they don't.
Yeah.
The focal deficits in a primary caudate hemorrhage are minimal, transient, or completely absent.
Wow.
The patient might be clutching their head in agony, entirely confused, but their motor pathways remain largely intact.
Because the head of the caudate sits anterior to the major descending motor tracts in the internal capsule. So the blood isn't physically compressing the highways that control the arms and legs.
Precisely.
But clinically, if you're the attending physician in the ER, the physical exam is entirely useless here. A ruptured aneurysm and a primary caudate bleed look identical.
The clinical exam fails entirely to differentiate the two pathologies. The definitive truth teller is the geographical distribution of the blood on the CT scan.
The imaging.
Right. If an anterior communicating artery aneurysm ruptures and bleeds through the septum pellucidum, the imaging will show a distinct pattern. Blood pooling in the interhemispheric fissure and concentrated in the lowermost frontal cuts of the brain.
But if it's our great mimic, the primary caudate hemorrhage, the radiologist is looking for a higher unilateral clot that is strictly confined to the head of one caudate nucleus, even if it has spilled over into the lateral ventricle.
Which brings us to a remarkable prognostic paradox. Because, as we discussed, ventricular extension in deep bleeds is usually ominous.
A very bad sign.
Yeah. But in a caudate hemorrhage, ventricular extension and subsequent hydrocephalus are incredibly common features.
Yet the sources indicate the overall outcome for a caudate bleed is surprisingly favorable. Like, they actually do well.
They do. The vast majority of these patients recover without any lasting physical or gross neurological deficits. The blood essentially takes the path of least resistance into the ventricular space without destroying critical motor relays.
I assume the neuropsychological impacts aren't as easily brushed off, though, considering the caudate's role in cognitive processing.
Right. It's not a perfect recovery. Long-term memory disturbances and subtle psychological or behavioral changes can definitely linger. But functionally, their physical independence is remarkably preserved.
That is a staggering contrast. You have two bleeds originating deep within the brain. The putaminal bleed brings devastating physical weakness and potential coma. Meanwhile, the caudate bleed terrifies the emergency department by disguising itself as a fatal subarachnoid hemorrhage, floods the ventricles, yet ultimately offers an excellent chance at a full physical recovery.
It completely dismantles the assumption that all deep supratentorial hemorrhages carry a uniformly poor prognosis. You can't rely on broad categorizations. You have to drill down into the specific microgeography.
So let's follow that geography outward to our final zone. We are leaving the deep central ganglionic structures of the brain and moving to the surface into the peripheral subcortical regions, the lobar hemorrhages.
The surface dwellers.
Right. And this is a massive chunk of the data, representing around 25% of all cases.
Yeah, we are shifting from the deep gray matter to the cerebral cortex and the underlying white matter. And because we are in an entirely new neighborhood, the underlying pathology completely changes.
It's not the same disease process.
No. The deep bleeds we just analyzed are heavily driven by chronic hypertension blowing out small penetrating arteries. Lobar bleeds operate under totally different rules.
The sources highlight this as a distinctly non-hypertensive zone. We are looking at a completely different set of structural vulnerabilities.
Exactly. In younger demographics, you're primarily hunting for arteriovenous malformations.
AVMs.
Right, AVMs, where a tangle of abnormal blood vessels disrupts normal flow. Or you're looking into the use of sympathomimetic drugs, which cause acute, severe vascular spikes.
Like cocaine or amphetamines?
Yes, but in the elderly population, the dominant mechanism is amyloid angiopathy.
Which is fascinating mechanically, because we aren't talking about systemic high blood pressure tearing a vessel. We're talking about beta amyloid proteins progressively depositing themselves into the tunica media and adventitia, like the actual muscular walls of these small cortical arteries.
The amyloid deposition fundamentally degrades the structural integrity of the vessel wall. The arteries become rigid, brittle, and highly prone to microtears and subsequent hemorrhage.
And the pathology is localized to the vessels of the cortex and leptomeninges.
Exactly. And because these bleeds are happening out on the periphery of the brain, rather than deep in the core, they aren't immediately knocking out the ascending reticular activating system.
The arousal centers.
Right. So the sources note that presenting in a coma right at the onset is significantly less frequent with a lobar bleed.
The central systems are spared, at least at first.
The deep central arousal pathways are largely spared initially. However, because the hemorrhage is irritating the cerebral cortex, which is this highly epileptogenic gray matter where complex processing and electrical activity are concentrated.
The surface is where all the sparks are.
Exactly. Lobar bleeds introduce a highly distinctive clinical feature, and that's seizures.
Blood is incredibly toxic and irritating to cortical tissue, right?
Yeah.
It acts as a massive catalyst for electrical storms.
Very much so.
Yeah.
And while seizures at the initial presentation of an intracerebral hemorrhage are generally rare across the board, the data shows they occur in up to 28% of lobar hemorrhages.
No, over a quarter of them.
Yeah. So if a patient presents with a brain bleed and a seizure, your immediate geographic suspicion should pull toward the lobes.
That makes total sense. And since the lobes cover the entire outer surface area of the brain, the specific deficits map perfectly to the underlying cortical function. I want to break down this lobar mapping because it's just a brilliant look at how the brain delegates tasks.
It really is a map.
Right. So starting at the front, a frontal lobe hematoma,
Predictably, you see upper limb predominant hemiparesis.
which perfectly aligns with the layout of the motor homunculus along the precentral gyrus. The pathways controlling the face and the arm are situated more laterally along the cortex, making them highly vulnerable to a frontal lobar bleed, whereas the pathways for the leg dive deep into the medial longitudinal fissure.
Keeping them relatively protected from a lateral surface bleed, yes.
Okay, moving posterior to the parietal lobe.
A bleed in the parietal cortex disrupts the somatosensory processing centers, resulting in sensory motor deficits. You also frequently see heminopia as the bleed damages the optic radiations traveling through the parietal white matter.
Which knocks out half of the visual field.
Right.
Shifting down to the temporal lobe, specifically in the dominant hemisphere, the sources note this causes fluent aphasia, which is a really fascinating clinical presentation.
It's very striking. The patient can generate speech fluidly, the cadence and rhythm sound entirely normal, but the content is devoid of meaning. It's a word salad.
Because the bleed is destroying Wernicke's area, knocking out language comprehension, but what's crucial is that their ability to repeat phrases is often preserved.
Yes.
That tells us the arcuate fasciculus, the wiring connecting comprehension to motor speech, and the primary auditory cortex are likely being spared by the specific geometry of the clot.
The exact shape of the bleed dictates it all.
Finally, the occipital lobe at the very back.
Purely visual processing. An occipital lobe hemorrhage predictably causes homonymous heminopia, obliterating the corresponding half of the visual field in both eyes.
While typically sparing motor and sensory functions entirely.
Exactly.
The lobar layout reminds me of a massive data center running specialized microservices.
Oh, I like that.
Yeah. A localized fire, which is the hemorrhage, might completely take out the specific server rack running the vision microservice, or the language comprehension microservice. Those specific functions go dark immediately.
Right.
But because the fire is isolated to the periphery, it doesn't melt the core routers. The central operating system, the patient's baseline consciousness, stays online.
The localization of damage is absolute. And to round out the lobar clinical picture, the overarching prognosis offers a degree of optimism compared to the deeper structures.
Because it's on the surface.
Right. The mortality rate for lobar intracerebral hemorrhage runs lower than the deep ganglionic locations, and the long-term functional independence for survivors is genuinely higher.
So what does this all mean? We have mapped out the entire upper region of the brain today, and the through line is undeniable, right? Anatomy dictates reality.
Absolutely.
We saw how the putaminal bleeds revealed the danger of incomplete data, proving that before the CT scanner, we were vastly overestimating mortality by only observing the most catastrophic cases.
We only saw the brightest star.
Exactly. We analyzed the fluid dynamics of thalamic hydrocephalus, realizing that early ventricular involvement isn't always a death sentence, but a mechanical pressure issue that offers a tangible target for surgical intervention.
A problem you can actually fix with an EVD.
Right. We unmasked the caudate hemorrhage as a brilliant, terrifying mimic of a ruptured aneurysm that ultimately leaves motor function intact. And finally, we explored how lobar bleeds operate under non-hypertensive rules, triggering electrical storms in the cortex and knocking out specific microservices based on pure surface geography.
The synthesis of all these sources really emphasizes the necessity of high-resolution critical thinking in modern neuromedicine. A diagnosis of a supratentorial hemorrhage is just the opening sentence.
It's just the start.
Right. The precise millimeter where the blood pools determines the underlying pathology, the immediate risks, and the trajectory of the patient's entire life.
Which brings me back to the concept of the telescope. For decades, the most brilliant medical minds recorded a 75% mortality rate for putamenal bleeds, believing it to be an absolute truth.
They trusted the data they had.
But it took a new piece of technology, the CT scanner, to turn the lights on and reveal the dimmer stars. The mild cases that had been there all along, miscategorized and misunderstood. It forces you to wonder, what hidden medical truths are we completely misjudging right now, today?
It makes you question everything we think we know.
What devastating diseases or assumed outcomes are we entirely misunderstanding, just waiting for the next generation of medical imaging to show us the full spectrum?
The limits of our technology continually define the limits of our assumed biological truths.
Keep questioning the data and keep exploring. Thanks for joining us on this deep dive. We'll catch you next time.